second speaker for the day, Professor Brian Williams. He is the Chair of Medicine at the University College of London and the Director of the National Institute of Health Research Biomedical Research Centre. He is a consultant physician at the University College of London Hospital, Chairman of the Council on Hypertension of the European Society of Cardiology, and a member of the NICE Hypertension Guideline Committee. And he is going to talk to us on intensive control of hypertension in the elderly. Over to Professor Williams.
See my slides?
Yes, we can. Perfect.
Good. Well, first of all, thank you very much to the Sri Lankan College and also the ESC for the kind invitation to present at this meeting and join colleagues on this call. I'm going to talk about intensive control of hypertension in the elderly, which is a pretty important topic and one that always taxes discussion at the guideline committees about how low we should go in terms of blood pressure control. So a very simple question, but quite complicated to answer. And I hope by the end of this talk, we can reach some conclusions based on the latest data. So the first thing to say is, if you were teaching students, they would just say, why don't we just reduce blood pressure to normal physiological levels in these patients? And of course, the answer is that most of our patients, particularly older patients, don't have normal physiology. They have impairment of baroreceptor function, particularly if they have long-standing hypertension. They have stiff arteries, so the blood pressure buffering is less effective. They may have atheromatous strictures in critical arterial circulations that might be compromised if blood pressure is lowered too aggressively. And they have aging kidneys where renal perfusion is critically dependent on perfusion pressure. So it is complex, and of course, every individual patient will be different. And as in all medicine, we must adhere to the oath of Hippocrates, who said, primum non nocere, first do no harm. And that's particularly true in the elderly population. And we have to remember that the absolute benefits of treatment get progressively less as you lower blood pressure towards the normal range. But ironically, the absolute harms of treatment in terms of blood pressure lowering get progressively greater as you get into those low levels of blood pressure, particularly in the elderly population. And I've been on a number of guideline committees, and we take these sort of questions very seriously. And these are the sort of considerations that you have to think about when you're trying to decide on a target. So what level of blood pressure should be achieved on treatment that is effective at reducing cardiovascular risk? So we need to know that. That is well tolerated and is safe. So the optimal target will not be the same for every patient. That's obvious. But ironically, guidelines often cite a specific single target. But when you consider frailty, comorbidity, age, and indeed the how high the blood pressure is at baseline and the adaptability of the circulation to blood pressure lowering, which will be impaired in older people, it's clear that we need a slightly different target for every individual. And therefore, when you set targets in guidelines, they should not necessarily be aggressive. They should be safe for everybody, and they should be conservative. And that should be the policy. However, we should recognize that we are doctors. We have been trained to make decisions, and the individual patient target will be adaptable within the recommended range. And that should be informed by individual patient characteristics and the experience of the doctor. Now, there's always been a tension between epidemiology and randomized controlled trials. If you go to epidemiology, the epidemiologists will say blood pressure should be below 120/80 because the hazard associated with hypertension increases once blood pressure arises above that level. But when you look at the trials that have specifically looked at more versus less blood pressure lowering or more intensive lowering versus less intensive lowering, these are much less numerous and actually have provided conflicting data. So, and the other thing to remember, and I'll emphasize this as we go through, the randomized trials have in fact focused on older people because you need events. They tend to focus on high-risk populations, but they do usually exclude two important groups: young people who are at low risk, who probably would benefit from much lower blood pressure targets than we often recommend, and older people who are frail, who are most at risk of harm from over-aggressive blood pressure lowering. So the policy for inclusion into trials tends to be quite conservative. But when we write guidelines, we are writing guidelines for everybody. So we need to take that into consideration. And when I was talking about this at the recent ESC meeting in one of the hotline sessions of a trial I'll mention in a moment, I produced this diagram to emphasize the complexity of decision-making in blood pressure targets as we age. So in young people, there's less heterogeneity. The patients are more similar in terms of their physiology. But as we get older and develop multimorbidity, we see a wide spectrum of heterogeneity in older people of the same age. Somebody will be biologically very old and frail, and others will be biologically young and independent and exercising every day. And therefore, clearly, the ability of this patient, the younger biological patient, to tolerate blood pressure lowering and benefit from it is probably greater than somebody who's biologically old and frail and approaching death. So we need to consider these factors in making decisions. The other thing we need to think about is the so-called U-curve or J-curve in terms of outcomes. And this was a study presented at the ESC in 2016. And it's from a French group called the Clarify study, in which they looked at about 20,000 patients on a registry who had proven ischemic heart disease but was stable coronary disease. And they looked at the achieved blood pressures on treatment and outcomes. And here we see that as blood pressure comes down, it looks like the sweet spot for these patients was somewhere around 130, just below 130, just above 130 systolic, and somewhere between 70 and 80 diastolic. Now, these are observational data with all the potential confounding, but that was the conclusion. And they also said that going below 120 is probably not a good idea, particularly in people with coronary disease. Michael Bohm and myself and others involved in the On Target trial also looked at this in over 30,000 patients. And what you can see here for all of the outcomes, if the blood pressure was above 160, there was increased hazard. If it was above 140, there was increased hazard. But the sweet spot in terms of outcome was somewhere between 120 and 140 systolic. And you can see this here for the primary outcome for systolic blood pressure and cardiovascular death. And subsequently, we looked at diastolic pressure in the same database. And here we've taken patients, 16,000 of them, whose blood pressure was controlled to the systolic target of less than 120, less than 140 down to 120. And then we asked the question, what is the relationship in those patients with the achieved diastolic? And you can see that cardiovascular death, and indeed all other outcomes, MI, stroke, and hospitalization for heart failure, the sweet spot, the lowest risk was in people with diastolic somewhere between 80 and 70. Now, based on this kind of analysis, because most of the data is observational from these studies, we came up with the concept in the 2018 European ESC/ESH guideline of a target range. And what we were able to say is that from the data, people with a blood pressure above 140 have insufficient risk reduction. We know that, and that's true at every age. We also know that if you say target blood pressure below 140, what happens is you tend to get clustering around 140, so that some people are not controlled and some people are only just controlled. We also know that below 120 systolic on treatment, the benefits are uncertain and there's certain evidence of increased risk of harm. And this suggested, therefore, that the optimal target range for blood pressure systolic was less than 140, and between 140 and 120 seemed to be the sweet spot for most outcomes. And probably for many patients, getting below 130 is optimal. And we said that the target range was less than 140 and aiming for 130 and going below that if necessary. And the diastolic target was less than 80. And this is how we specified those targets. So I just wanted to explain how we got there in 2018. And if we look at the older patients, what we said was, first of all, get blood pressure if you can below 140 over 90, because the benefits are unequivocal. We know that that is going to produce benefit. And don't just leave it at 139, but try and get down to 130 if you can. That will make sure that the blood pressure is consistently below 140. But we didn't recommend necessarily going below 130 because at that stage we weren't convinced the evidence was sufficiently good to justify that for every older patient because of the increased risk of harm. And we also said, particularly in the elderly, consider frailty, independence, and tolerability treatment. For younger people, we said get down to 130 over 80 or even lower if blood pressure is tolerated. Now, subsequent to those guidelines, I was involved in a meta-analysis from colleagues in Taiwan, and actually there have been a number of meta-analyses, but I focus on this one because I know it well, and the results are similar. So what we looked at here were 18 trials, 53,000 older people, 60 plus, and of course, the definition of elderly is a moving target as well. I think calling somebody over the age of 60 elderly is probably stretching it a bit, but the mean age of this population was 74. And the results were that with more intensive treatment, achieving a blood pressure below 140 systolic, the reduction in stroke was 32%. There was a reduction in heart failure, incident heart failure, of 23%. There was a reduction in cardiovascular death of 32% and of MACE of 17%, when compared to those whose blood pressure was above 140 systolic. So unequivocally, getting below 140 is beneficial. In 2019, we said there was insufficient data to evaluate the effects of more intensive lowering below 130 versus standard control below 140, because the only study that had really looked at that in detail was the SPRINT study, which contained about 30% of patients who were over the age of 65. And I'll show you that data in a moment. But we didn't think that on its own was enough to drive blood pressure in all elderly patients below 130. Interestingly, when we looked at adverse effects of blood pressure lowering in the elderly, there were very few studies that reported side effects related to antihypertensive therapy, such as falls, fractures, syncope, hypotension, or electrolyte abnormalities. And therefore, we had to use a group composite measure to look at adverse outcomes. And this pooled data suggested that there was no obvious increased risk of reported side effects with more intensive blood pressure lowering in the people in the trials. But there was a trend for older people to experience more renal dysfunction with more intensive blood pressure lowering. And you can see this here. Basically, very intensive therapy was beneficial on almost all outcomes, and particularly in older people. But the one thing that was adverse in older people was the increased risk in people over 75 of developing significant renal dysfunction. So that was the only signal that we saw of potential harm. And you can see here these achieved systolic blood pressure and outcomes in older people. For coronary disease, just like that observational data, the sweet spot is somewhere around 140 to 130 systolic. For stroke, risk, keeps coming down as blood pressure comes down. For heart failure, the sweet spot is around 135. But for renal failure, as blood pressure is lowered, we see an increased risk. So these are important issues in the elderly, and we concluded that when treating older people with a mean age of 74, age itself did not have much of an effect on modifying the beneficial outcomes from blood pressure lowering, except for renal failure. And therefore, close monitoring of renal function may be warranted in the management of elderly hypertension. But also remember, and I think this is so important, these people in these trials were independent. They're elderly people, but they're all well enough to volunteer and participate in trials. And I don't think that's been emphasized enough, that this does not represent the broad spectrum of the elderly population, many of whom would never be motivated or well enough to participate in clinical trials. So clinical trials are a bit more selective, particularly in the elderly, and that's where the evidence is. Now, I mentioned SPRINT. So in SPRINT, which you know, there were about 4,600, actually, half the patients were over the age of 75 in that trial. And these were community living elderly patients. And you'll know the mean age was 79, so quite old. Their seated blood pressure, however, was pretty reasonable at baseline. So remember, they weren't treating people with very high levels of blood pressure and bringing them down to very low levels of blood pressure, because I'm sure they'd have had a lot more problems if they'd been doing that. And the estimated GFR was pretty good for that age group as well. And these are the achieved blood pressures. The way SPRINT measured blood pressure, 123/62 in the intensive group, 134/67 in the less intensive group. But this was achieved by adding just one medication. So these were not difficult to control. They're not representative of most of the patients I see in my clinic, where I never get blood pressure down to these levels by adding one drug, whether they're old or young. And they said they were all community dwelling, and 30% were frail and 55% were less fit. But I think all things are relative, and this was probably quite a healthy population. But they did get benefit from that more intensive blood pressure lowering on all cardiovascular disease outcome, 34% reduction, similar to our meta-analysis, and a big effect on heart failure and all-cause mortality. And there was no interaction with whether they were more frail or less frail, more fit or less fit. So this prompted and just to comment on serious adverse events, apparently they were comparable between groups, but remember, this group of patients did not have particularly high baseline blood pressures, and the blood pressure lowering wasn't particularly aggressive. There were more adverse effects in more frail patients, but there was no increase in falls or orthostatic hypertension. And as in our analysis, there were more electrolyte imbalance and acute kidney injury in intensively treated patients. Nevertheless, this prompted the Americans to say that in the treatment of hypertension in older people, the goal is less than 130 in everybody for non-institutionalized ambulatory community dwelling adults. And also they recommended treating all elderly patients pretty much when they were over 65, because they use a risk calculator, and once you're over 65, most people would hit the threshold for risk. And therefore, they'd be treating in the United States everybody with a blood pressure above 130, which is pretty much everybody once you're 65, and they'd be targeting them all to less than 130. But there was a lot of controversy in SPRINT about how low the blood pressure really was. And I love this study, which was published more recently. So these were patients in Sprint who also had their blood pressures measured in their routine clinic just after they'd been to their Sprint clinic, and the routine blood pressures were measured on the VA hospital system. So this is standard treatment on Sprint, where blood pressure was supposed to be around 134 systolic. Actually, if you look at their usual clinic blood pressures in the same patients around the same time, it was about 140, so not even controlled. And the intensive group, which they said they got down to 123 in the older population, actually, the intensive group was only just below. In fact, by the end of the study, was around 130. So I would say that in Sprint, probably, they were really looking at a blood pressure that was around about 140, i.e. at the upper end of our acceptable control, versus 130. And that's why I think our guideline in Europe has got it spot on, with around 130 or below if tolerated. And then this was followed by the STEP study, which I was a discussant at ESC, which is this study out of China, where 8,000 adults have been aged 60 to 80 years with a blood pressure above 140, all on treatment, were randomized, just like Sprint, to a more intensive or less intensive goal, although they measured blood pressure in a more conventional way. And the intensive treatment reduced stroke by 33% and cardiovascular events by 26%, and acute heart failure by 73%. And it was well tolerated. And it was using treatment strategy recommended by our guidelines, and the blood pressure achieved in that study, standard treatment about 135, and the intensive group about 125. But again, I come back to the fact, and this is nicely summarized in these abstracts that you get from the New England Journal of Medicine these days. But I just want to get back to the fact that, again, if you look at this population, they were called elderly. The mean age was actually 66, and 75% were below 70, so they were pretty fit. The baseline blood pressure, again, was quite low. A third of them actually had a systolic below 140 at baseline, so they weren't even hypertensive by conventional European standards, and only 2% had renal impairment. Excuse me, I've got a frog in my throat. 2% had renal impairment, and 6% only had cardiovascular disease, which are low rates. So these are quite a healthy group in this particular study. So where does that leave us all? We've got two studies, one in China, one in the United States, saying more intensive, but probably in quite healthy free-range elderly. And we've got other guidelines being concerned about over-aggressive treatment in the elderly. Well, as I've said, the current guidelines in the US is less than 130 over 80 in everybody who's old. In Europe, we say get everybody below 140, 90 if you can, and aiming down to 130, 80 if tolerated. But maybe now we can be a bit more open-minded. And what I've suggested is we need, particularly in the elderly, to have a more bespoke approach, a so-called tailored blood pressure targets. So people over the age of 65, get them below 140. The evidence is unequivocal. Aim to go below 130. Aim to 130 or lower in those who will tolerate it, but accept that this is more likely to be possible in those who are independent, active, and less frail, and in those with fewer comorbidities. So blood pressure treatment, in conclusion, in the elderly needs to be individualized, taking account of their life expectancy, their frailty, their comorbidities. And if you do treat more aggressively in the elderly down to 130 or below, we need careful monitoring for adverse effects, especially regular checks on renal function, particularly in the early stages of treatment, because you might get a big reduction in renal function in some of these patients where their renal perfusion is pressure dependent. So I think it's a difficult question. I think you cannot say there's a single pressure for everybody. And we do need to use some medical skill in assessing our patients and deciding what might be the optimal goal. But we can be definitive that less than 140 is for all. And I really like this quote, which applies to a lot of medicine, but I think particularly for the question that we're considering today, it's from William Osler, one of the great British physicians, who said this: we must make sure that the patient who takes a medicine doesn't have to recover twice, once from the disease and once from the medicine. And I think that's particularly true in treating elderly patients with hypertension. Thank you very much for your attention.
Well, thank you, Brian, for this great talk. I don't know whether you can hear me in the lecture room. And if I may ask one question, I find it interesting that you say the renal side effects of lowering the blood pressure more intensively are really in the forefront of what the problem is. Now, is this an effect of the lower blood pressure, or is it potentially a side effect of the medication that is used to lower the blood pressure?
I think it's a combination. It's a great question. But I think you've got to remember, in the elderly, we're all losing nephrons as well as we're losing neurons as we get older. It's a natural process of decline. And once you get down to a critical level of nephron loss, which you will get to when you're about 60 or 70, you will hyperfilter. So you'll open up your renal arteries to allow more perfusion to try and drive your GFR. And therefore, as you get older, you become much more blood pressure sensitive to changes in GFR than you are when you're younger. You've got a bigger reserve when you're younger, but when you're older, you don't have much reserve capacity, and your GFR will decline if your blood pressure declines. And then on top of that, as you say, we use RAS blockers, and RAS blockers dilate the efferent arteriole, which make us even more sensitive to renal perfusion decline, particularly in the elderly. I think the trials are demonstrating that. I don't think we need to be obsessed about it, but we do need to measure kidney function in elderly patients as we titrate their blood pressure down. And once it's stabilized, it shouldn't go down anymore. And in fact, will probably remain more stable for longer once you get blood pressure better controlled.
Thanks a lot. A question from the audience, maybe, or from the panel?
Yeah, thank you, Professor William, for that excellent presentation. Just one question. With regard to elderly who has ischemic heart disease, most of the time these patients are having isolated systolic hypertension. So controlling systolic blood pressure would reduce the myocardial workload. But on the other side, the coronary perfusion would depend on diastolic blood pressure. So how would you strike a balance of someone who has established coronary disease, unrevascularized, presents with normal or optimal diastolic blood pressure, having isolated systolic hypertension?
It's a very good question and a very common one, obviously, because we've emphasized that there is this U-curve type of shape to the outcomes. In reality, there's a U-curve even before you start treatment. So your lower diastolic at baseline is also associated with increased risk, and it's related to the stiffness and the lack of compliance of the arteries. I always say this to my patients, that the most important thing is to get the systolic controlled, because that's the thing that's going to give you heart failure and stroke as you get older. There's the big components. The diastolic is important, but it's more important in monitoring adverse effects. So if the patient is not getting dizzy spells, is not feeling unduly tired, if renal perfusion is okay, then I will continue to lower the systolic blood pressure in below 140, and certainly try and get it there. As you go lower, if the diastolic's low, then you may get more problems in terms of tolerability, because diastolic is more representative of mean pressure, and therefore they may get more tired, more dizzy spells, feel less well if you try and drive the systolic blood pressure down, which results in further diastolic lowering. But I wouldn't ever avoid trying to get the systolic controlled, because it will, in the long run, be beneficial to the patient, providing that they tolerate it. So it's a good example with that comorbidity where you need to use a bit of medical skill and make judgments about how well the patient's tolerating the intervention. But still, I think the target should be to go below 140 and try and get down to 130 if you can, but monitoring more closely for adverse effects in people with ischemic heart disease or indeed any other significant comorbidity.
No, thank you. I think it's time to move on to the next presentation, and maybe we have a little bit more time later to discuss a bit more. Fantastic talk. Once again, great question also.